Coming up on today's episode of The Health Review.
I have less tolerance when people don't care for women in the way they need to be. When women get sent away from somewhere else and they end up with me and they haven't been offered HRT, or it hasn't even kind of crossed somebody's radar, I do feel really, actually just feel quite angry. It isn't good enough. We hold up the world. 51% of us hold up the world.
Dr. Nikita Kanani MBE is a former National Medical Director for Primary Care at NHS England, where she helped lead the UK's COVID-19 vaccination programme
and suddenly realised that actually there was something very, very significant and scary coming towards us. I don't remember really sleeping or eating, and I did talk to my family and I was like, I'm going to disappear for a while because we had to physically be together to plan this vaccine rollout, and we camped out in our offices for weeks and months on end with the military because it was such a complex programme.
Hello, welcome back to the show. Thank you for joining once again. And today we are discussing women's health. Finally, it does feel like women's health is getting more attention. I don't know about you, but I'm seeing more and more podcast interviews, news articles about change. But for too long, we know it's been overlooked and underfunded and often misunderstood. So many of us have experienced long waits for, a diagnosis, but there's still a long way to go. And how do we continue to make change? That's the question. What would modern women's healthcare actually look like if it was built around prevention, innovation, and equity? Those are the questions for today. And my guest today is someone who's working at the very heart of those questions. Dr. Nikita Kanani MBE is a former National Medical Director for Primary Care at NHS England, where she helped lead the UK's COVID-19 vaccination programme and a trusted voice on policy, equity, and system change. Thank you so much for coming on the show, Dr. Nikita.
It's so lovely to be here. Thank you for having me.
I love everything that you've done so far in your career. Am I right in thinking that you were the first female medical director for primary care
in
NHS England?
Right.
Wow, that's a huge achievement. And as I said, it was during the COVID pandemic, which would have been just such a, chaotic, emotional, ever-changing time. It was such a kind of strange time for everyone. I can't imagine how it was for you. So how was that for you?
I think you've described it really well. I think it was the combination of it being very unexpected and incredibly physically, emotionally, mentally demanding. We had that hint that something was coming, and then that was around the time where I thought I'd done my role as the National Medical Director for Primary Care. I'd negotiated this new contract for primary care. So I thought, I've done something great. I brought billions into the sector. I'm going to go and do something different. And that was sort of January 2020, and suddenly realised that actually there was something very, very significant and scary coming towards us. So I decided that, obviously, like many of us, the only thing I could do was sort of face it head on, take all of that unknown and that uncertainty and try and sense make. And it was, like, for many people, just the most dark time in so many ways. And at that time, my children were quite small. I'm a GP. My husband's a practicing GP. So we were doing things like hot clinics in between. And they were the clinics where you'd see people with COVID symptoms. So we were doing hot clinics. I was working with kind of the policy and the politics of the time to write the protocols and the procedures to manage the pandemic, and also keeping my children at home because I thought that was the only way to keep them safe. So I'd have like this 6-7-year-old, my daughter next to me. My son would sort of hide away, but my daughter next to me, while I was on, with the Prime Minister and with ministers and sorting out kind of big, complex national policy stuff. And then my daughter would be like, and so what happened with the Egyptians, Mummy? And I was like, I'd be like, could you do your homework? No, we have to. And she's like, but Mum, in school, the teachers teach us stuff. And I was like, okay, great. So it was a bizarre time. I don't remember really sleeping or eating. I lost lots of weight, and then I put on lots of weight. Just before Diwali of that year, I was asked to then join the vaccine programme. And Diwali, as it's approaching in a few weeks, it's all about light. And that was the light. And I did talk to my family and I was like, I'm going to disappear for a while because we had to physically be together to plan this vaccine rollout. And we camped out in our offices for weeks and months on end with the military because it was such a complex programme. And my family said it was the right thing to do. And it was in many ways because it meant that we got back to some of the things we loved and the people we loved. But yeah, they were the hardest few years of my life, as they were for many people. Very, very destructive for a family who are trying to just navigate things. But I don't regret it. I couldn't because we get to sit here and talk to each other and do all of those sorts of things. So.
And also, you know, the vaccine program was a success, and that was a huge sort of triumph for the NHS and in terms of speed and the rollout. And it was also such an uncertain time. And I think not many governments around the world were prepared for that.
No.
I worked in news at the time, so I was reporting on a lot of the I guess the U-turns at the time with schools are, you know, exams are going ahead. No, they're not going ahead. And it was such a, just an unprecedented time, I guess, for everyone. I feel like you must some days wake up now and look back at that and think like, was that real?
I do very often. I think a few things often when I wake up. One is very much, did that even happen? The second is I've always been, you know, sort of fairly type A, worked quite hard, kept quite busy. That period really messed with my kind of, my cortisol system, my response system, because I still often wake up ready to go in a way that I don't think I was, you know, you do when you wake up and you get the kids ready and you get on with your day. But now I have that kind of edge. I'm still anticipating something to come through. On WhatsApp, on email, I'm waiting for something. I notice that, and it's 5 years on, and I still notice myself in that, well, the fight response of that flight and fight response. And despite, you know, a lot of inner work on myself and how I look after myself, it's still very much there.
Yeah, I can't imagine the levels of stress that you underwent at that time. Potentially, you know, seeing patients, but also policy. Yeah. And I guess it's quite unusual because you wouldn't have been taught policy. No. You wouldn't have been taught politics when you were training to be a doctor. And then suddenly you find yourself in this role at NHS England, where I'm guessing quite a lot of it was, right, like the nitty gritty of policy, which is quite a hard thing to learn.
Yeah, and look, through my career, I've always done things alongside medicine. So even as a medical student, I was that really annoying medical student that loved everything and then got involved in everything that went on. And so over the sort of 2 and a bit decades I've been kind of practicing in the NHS, I've done kind of leadership courses and I've done a master's in commissioning. So I've learned pieces along the way. But nothing could have prepared me for that time. And I had to actually go back to very basic principles. How does this sit with me? How does my gut feel? Do I feel like I'm doing the right thing? Because I was straying in spaces that were so grey so many times. Am I making sure my voice is heard? Am I in a room full of very senior or very powerful white men, and am I reducing my voice because of my cultural upbringing? There were some really complex things and also some very simple things. And my dad always says, you know, you do things dil dinner, so from your heart. And that was the thing that ended up being the most important thing. When I'd hear things that I didn't trust, and I would be like, I can't do that. That isn't the right thing. This is a way through, or this is what's important. So those things that are very innate started to be the things that I learned to trust. And then that stayed with me, you know, that ability to listen to your heart, you know, trusting your gut. Very, very important.
But also, I guess you had the medical experience and you were a voice for the people, I guess, because you were you've been a GP and you've seen so many people.
Yeah.
You hear what people are struggling with. You hear what needs to change.
Yes.
So I think it's really important to have, you know, actual doctors in that role where you can be a voice for the community.
You're spot on. I've never not been a medic. So I've done a range of different roles over the years, some that are very all-consuming. I have always practiced. I've always then gone out to our practice in Lewisham, which is a very diverse, very, you know, lots of complex things in that society, in that community going on, lots of very understandable trust issues, brilliant people, amazing food. But I've always been back out into the community. Even like in the pandemic, I was always seeing patients. And before we had spaces for people with COVID to go to, you know, we didn't have the right kind of protection. We didn't have access to protection. So I remember one of my senior partners bringing kind of overalls and stuff. And I just see people, you know, in the vaccine program, I think I didn't see patients for 2 and a bit months. And that was genuinely, I was sleeping at work. I was in and out of number 10 or I was at work. That's all I did. But the first moment we were starting to vaccinate, I was in the vaccine clinics vaccinating as well, because to your point, that ability to bring that lived experience in, I think changed parts of the program. To your point about equity in the opener, we were seeing very quickly that mainly white, well, men and women, but white men of an older age were able to were accessing the vaccine and taking it up. And we're seeing uptake in other communities already, like falling behind very quickly. And it was New Year's Eve 2020. I spent 4 hours in our care home vaccinating. And I was talking to a Black woman who, since then I've talked to her, she's happy for me to talk about that journey. She was a care worker. She was with me as I was going around vaccinating, just to introduce me to the patients and what have you. And right at the beginning, she was like, I'm absolutely not having the vaccine. My brother's a policeman and he won't have the vaccine and we don't trust the vaccine. 4 hours later, she'd heard me do the patter so much. I had 1 dose left. And remember when every single dose was I called it liquid gold.
Yeah.
And we had 1 dose left. And I hadn't been vaccinated at that point because I was very anxious. I was very aware that, like, when I had my vaccination was important. I didn't want it too early. I didn't want to take a dose from somebody. But equally, at some point, I needed to be vaccinated to carry on practicing clinically.
Yeah.
Anyway, there was a dose left. So I was like, okay, we've done all the patients. We've done all the staff in the care home. And this one woman came back. And so I was like, okay, maybe I'll have it. All the other staff had it. And she came back. She went, actually, I will have it. I trust you now. And literally her words were, I trust you now. I'll have it. About an hour and a half later, I'm at number 10 talking about that story, that specific story to the PM, going, we need a different approach for communities because this is not about, hey, here's our open door, come in, get your vaccine. This is about trust and relationship building. And actually, to be fair, that was heard. And for about 6 or 7 weeks after, every Sunday at number 10, the PM and I would do calls with different faith groups, community leaders to help build relative, and it is much more complex that, but relative trust with communities, so that then when teams went out to those communities on the ground, they would have some sense of wanting to have the vaccine. But yeah, you're right, that connection has always been my golden thread, and I don't think I'd ever stop.
I think it's so important, and as you say, people trust figures who have been in the public and in the community asking those questions. And it is remarkable how the virus arrived, I guess, to the UK. I think it was February. It was
February,
February 2020. And then by Christmas, people were being vaccinated.
Yeah.
It's just, fascinating how that at speed.
And then suddenly thousands of sites, and then suddenly millions of vaccinations. And I remember friends sending me these balloons to work, a 1 and a 0. And I was like, what is that? And they went, we've hit 10 million vaccinations. Wow. And I was like, and we'd been watching the data, don't get me wrong, gosh, I was watching that data every few minutes, I was refreshing, but I hadn't until that point kind of contextualized it that we've given 10 million doses, oh my God. And I still get goosebumps when I talk about it because, it was horrible at times. I had death threats, I had and I still get some very toxic anti-vaccine stuff. But fundamentally being able to say to my kids, you can see your grandma, who had been she's a community pharmacist and who'd been exposed for months and months and months on end, being able to say, right, grandma, you have vaccine, kids, you can see your grandma, like all of those things made it all worth it.
It's a shame that those voices, though, still, find a way to reach people on social media. And that's, one of the downsides, I guess, of being in the public and working in public services, that there are lots of opinions.
We've seen it like this morning with the Tylenol stuff in the US and autism. And then not amazingly, we've got a great Medicines Healthcare Regulation Authority, the MHRA. So the chief exec has already come out and gone, it's absolutely fine, you know? And having those trusted voices, not negating the debate, but kind of going, okay, that's happening over here. Let's present the facts back to people is really important.
I'm guessing when you were in your role at NHS England, some of that would have been about women's health as well. Yeah. I know you're passionate about this topic. You've obviously worked from the GP surgeries to the top at NHS England. But I'd love to know what kind of patient story has most shaped your drive to improve women's health in particular?
Yeah, it's a great question. And I think in one sense, there are so many stories. There are really complex stories of women that we hold in primary care because of that wait list you mentioned. So about 750,000 women are currently on a gynae wait list. So that means they're waiting for a conversation or an investigation or some sort of treatment for their women's health issue. So that's 750,000 women. And what happens then is women sit in primary care a lot longer. They come back and forth to their GP. So there's lots of examples of complexity that I could talk about. I think actually the story that still sits with me is the first woman who helped me to realize that Black women really didn't trust HRT and that menopause kind of narrative that was coming out. I'll just unpack that for a moment. So I'd often be, the one who would see all the women who are perimenopausal, and I'm very supportive of HRT. I think it's hugely important and beneficial for the vast majority of people, but obviously speak to a clinician if you're thinking about it. I found that I'd bring people in. I thought it was really important to see people, to have that human connection. If I was speaking to a white woman, almost the first time I saw her, she'd say yes to HRT. And the first, there's a particular case, a Black woman that really stood out for me. And obviously I'd seen lots of people, but this one, I think maybe I was in parallel seeing somebody else. And it took her 4 face-to-face appointments to feel confident enough to take the HRT. And I thought, gosh, it's a simple case, but it tells you so much about equity, about wellness, about prevention, about people's relationships with their body, about people's relationships with healthcare. And that really jarred for me. So this is way pre-pandemic. And then through the pandemic, through the vaccine program, even though we were working so hard on making sure people didn't get left behind, we saw women not only deprioritizing themselves, but, having to make sure that everyone else was vaccinated. We'd have queues, when we had that bit of vaccine left, people would wait on a sort of wait list just in case, men would find time to be in the list, women would be at home making sure that everyone was safe. And it just became more and more clear for me. And then I had a case of a woman who basically had heart disease. Heart disease presents differently in women most of the time. It's much more, it sounds more like a pain, a discomfort in the throat. It can feel a little bit like indigestion. You won't necessarily get the heavy crushing pain, but more feelings of anxiety. And I remember seeing somebody and she was minimizing it while I was seeing her daughter for something else. And I was like, you're not well, talk to me. She's like, oh no, again, very much a caretaker. You must be busy, doctor. You carry on, I'm fine. Anyway, she did have heart disease. She was it was before actually having a heart attack. But I genuinely believe if she'd sat with that for any longer, she probably would have ended up having a heart attack. So it was a combination of things that are quite simple, but also just kept telling me that despite all the things that I was doing in primary care nationally, through the pandemic, through vaccines, we still weren't levelling up for women in a way that was really meaningful.
That's so interesting. Yeah. I went to a event the other day with Dr. Vonda Wright from the US.
Yeah.
She's doing amazing work. She's got a book that's come out, and Dr. Louise Newsom was there, and she's a big menopause champion. She's got her clinic. They were doing a panel at the end about all of these things. And actually, I think a lot of women don't realize that heart disease is very common, actually. Yes. And it's one of the leading issues for women's health as they age. And not only that, it was they did a panel. There was a woman who stood up and said, I was actually in A&E last night with a suspected heart attack. But they did all the tests and everything was fine. And I've just been left with no answers. And I've been to my GP 10 times with palpitations, with I don't feel myself, I can't think straight. And I haven't been offered HRT at this point. And it's amazing that you can get that far down the road where you actually think you could be having a heart attack and still no HRT has been presented, or it's been difficult. I know there is nuance around it because of the Women's Health Initiative study 20 years ago, which we know now has been, disproven in many ways. But some practitioners are still a little bit concerned about prescribing it. There's also, if you have a history of breast cancer, I know for some women it's more of a nuanced question rather than HRT is definitely for you.
Yeah.
Is that hard to navigate with people?
It's really difficult. But when I say it's difficult to navigate, I actually find that difficult as a clinician, because I've spent, at least a decade kind of very much caring for, championing clinicians in my national leadership roles, because we are working, and my colleagues are often working in complexity and pressure and unprecedented demand as our society grows and ages. So it is difficult, but I have less tolerance when people don't care for women in the way they need to be. So my training had very little women's health in it that I can recall. Certainly almost nothing on menopause. I think it was probably a couple of hours. It's changing a little bit. It hasn't changed enough. Many of us have gone out and sought out kind of women's health courses and like menopause certificates and things like that to make sure that we really understand what we can offer women. And making sure that women get the right kind of time and space to be listened to. When women get sent away from somewhere else and they end up with me, and they haven't been offered HRT, or it hasn't even kind of crossed somebody's radar, I do feel really, actually just feel quite angry. And even now, even though I've done lots of things to try and change the system and improve the system, it isn't good enough. We hold up the world. 51% of us hold up the world, and we look after communities, and we work, and we live longer than men, but we spend 25% of our lives in more ill health. We live longer because I think we just feel like we have to. And we carry all of this chronic stress, and we become society's shock absorbers. And we can't put a system around women that keeps them healthy. There's a strong economic argument that you'll know as well. If we return women just 7 days of wellness a year, we will release $1 trillion into the global economy, because it isn't just that they are well, that we are well and we kind of go to work. We do support other people again and again. It's very, it is very much in our behaviour set. So there's a really clear kind of social, medical imperative. There's a financial imperative, and now we can feel that kind of moral imperative, which is why it's still ridiculous that clinicians aren't properly trained in women's health. They need to be, and they need to have access to that training. It has to be normalised. But also women have to be funded to kind of do things in women's health for women, because, and we know this from all the work that we've done, we've seen kind of internationally, but representation is the way that we can design services around women. So men designing services for women doesn't work. I mean, there's some great men out there doing parts of that, and I'm grateful for the male allies in my life and in my world. But the reality is, unless you've been through part of that and you understand some of those complexities, you can't design for women in mind.
Sorry to interrupt. If you're enjoying today's episode, please do subscribe or give it a follow so we can keep giving you excellent content and bringing on amazing guests that hopefully you're loving on the Health Review podcast. Now back to the show. Yeah, and what's frightening is it also starts from a young age. So it's not just, we know the horror stories of menopause, and the more people are talking, the more frightening it actually gets when you realise how many women have been let down through perimenopause, where they've been dismissed with showing quite, whole body symptoms, from brain to heart to vagina to periods, everything. So we know about that, but actually it begins much earlier.
It does.
Many young women with endometriosis, PCOS, fibroids, and you do hear that the average time for a woman to get diagnosed with endometriosis is 10 up to 10. Is it 9 or 10 years?
Reports are now showing it's about 9, but we're looking at 9 to 10 years, and you might see 8 to 10 different professionals in that time. So you don't have continuity of care. You can't get ahead of it. And the real problem here is, it's so good that you brought it up, because polycystic ovarian syndrome, endometriosis, adenomyosis, all these things that affect your, just, a very basic level, like whether you have periods and what they're like, if not found out and if not managed well, affect your fertility, your reproductive journey. And if they affect that, that also affects the sort of menopause you go through. So you're right, it's a whole lifetime impact. And actually, if we can support young women earlier to understand what a healthy period looks like, and who live through their cycle, and I'll come back to that, they are much more likely to be diagnosed earlier and cared for and have a reproductive journey that works better for them. My daughter's 13 and she doesn't mind me talking about her, but her period relationship has been completely different. We talked about it for ages. I had a box ready. She had period pants. She knows all the different ways to manage her period through her actual, when she's actually menstruating. But we also think about what happens through the rest of that month. How might you be feeling in your luteal phase? What is going on? How might you need to feed yourself? Oh, right, you were great at hockey this week, but you feel really crap in hockey that week. What might be happening to you? And her ability to understand her body is important for her, but actually it's really important for her big brother, who's like 17, nearly 18, and he has a great relationship with periods as well. I was very clear that he had to understand just as much as she does. And my husband's been brilliant, because occasionally my daughter will be like, oh, I've bled through 18 pairs of pants. Aww. And my husband's like, I can deal with this. I can help you. Come on, and normalizing it and talking about it means that, yes, we do the healthy period stuff, but then when people aren't having periods that are healthy, we can pick that up much faster and talk about it and get to the cause and help women much more easily, young women.
Absolutely. And I think it's I guess, investing in our health ourselves from a younger age as well.
Yeah.
I think my generation, I guess, millennials, like, I was in the era of going to the GP and saying, if you had heavy periods or if you had acne or whatever it was like, go on the pill, see you later. I had chronic UTIs, I was on forever antibiotics, and that's had effects now on my gut health and things where I'm still 10 years later still trying to fix it. Obviously, that we've spoken about some of the main sort of pressing issues in women's health, what they are, heart disease and menopause. But how do you think we're going to change this going forward? It feels like the communication is getting better now. Yeah. It feels like the awareness is getting better. Social media has actually been a brilliant tool for women.
Really has.
Documenting, speaking out, sharing their journey. So it feels less taboo.
Yes.
But is that necessarily translating into real change in terms of when someone shows up to see a doctor?
I think it's helping women ask for and advocate for themselves better. And I say that with hesitation, because actually that isn't the whole answer. It shouldn't be on the woman to say, oh, I think that this is the problem, right? Because that places a lot of pressure on you having had the right information and being in a community and being able to share. So in terms of access, actually the most deprived communities won't often have the time and the space to have these kind of conversations and everything. So that's one thing. But I do agree that the fact that on social media, in communities, on Reddit, people are talking about stuff, it does mean that women are more likely to go and ask for things that they need or just share what they're worried about. And I love it. I love it when a woman comes in and goes, okay, these are different things that have been going on. I was on Google. I think this might be the thing. There's this whole thing of like, doctors not liking their patients Googling stuff. I'm like, Google away. Come to me. Let's look at stuff together. Why did you think that? Okay, if you use that source, that's a great source. Next time, try this resource, try that resource, because that helps us understand our bodies better and know, as you said, know when things are not right and know when you might need help. But to design those services more holistically, to actually see that knowledge turn into service kind of design, I think there's a couple of things and it's come out when we've talked. It is that holistic care. So endometriosis is not just about periods, it is about nutrition and how we look after ourselves. So I practice as a lifestyle medicine practitioner as well, because I do think that there's a really important point about not just focusing on women's health, but the health of women. So how do we look at women in their whole self? So all of the other medical and clinical things that might go on, but also your sleep, your nutrition, your relationships, your work, what else is going on in your life? And that has to be part of that service design. So I often think of the service design as and it was in the Women's Health Strategy a few years ago, as that kind of one-stop shop. Women are busy, they deprioritize themselves, they're used to not being heard. So you need to have that space where you can talk about what's going on. We can think about you in the wider, more holistic sense. We can do your diagnostics on the same day, and then we can give you the sort of support that you need. What doesn't work, and what we're seeing through traditional kind of waiting lists, is women are coming in with something, they'll go away. They'll have some bloods done, they'll come back. They'll need a transvaginal ultrasound scan. The wait list is 7 or 8 months. That doesn't work. So our ability to kind of design both physically and kind of theoretically with that woman right at the center and coming to women as well. Women don't always like have time to go to the doctor's surgery. Let's make sure it is at their places of work, at the, wherever they're shopping. And I don't mean that as a women are shopping thing, but like, where are women going, and let's go to them and make sure that they can then have that care, because that's how we get into prevention as well.
And prevention is huge. We know that's really the key to kind of sorting this out. And it's something we talk about a lot on this podcast, about the whole body aspect. And what I've liked through my treatment I've had with functional practitioners is the longer appointment times. You do get up to an hour sometimes. You might fill in a very long, detailed questionnaire, test results that you've had. And it's kind of that lifestyle, functional approach of, right, what are we seeing here? What's a pattern that we're seeing? And often, we know that the NHS in the UK is so overstretched, and you go and see your GP, you've got 10 minutes, and you're kind of just reeling off all these symptoms you have, and it's really hard for them to connect the dots. When I was seeing urologists, for instance, and they would put me on antibiotics, and they do surgeries to try and figure out what was going on, why I was getting UTIs, and never once was it suggested, like, how's your diet? How's your you drinking? Are you sleeping? Are you eating sugar? I literally did like 2 surgeries to try and sort of have a look and move things around and see if it would help. And actually the only thing that helped was quitting drinking, adding probiotics, going on a clean diet, and it transformed, and I've never had a UTI since. And it's been many years. And I just think, obviously that's not the case for everyone. Everyone has their own scenario. But for me, lifestyle, and this is why I was so passionate about doing the show, because it's like we can take control of our health, but it's the education that needs to be there, and it would be good if things could catch up alongside that. Having that holistic approach, I guess, is really important going forward. I'd also love to talk to you about the mental health side of things. We know that's very linked to women's health. Hormonal changes for many women, perimenopause, hormones up and down, it can be a really difficult time. Do you think the link between hormones and mental health is still massively underestimated in traditional medicine?
I think so. And I think it's because we have, and I cut me open, I'm NHS. I am so NHS, my parents were NHS pharmacists, but it's not a national health service. It's a national sickness service, and it tends to be a national sickness service for physical issues. So that's how many people are trained, and trained to look out for the physical and then to treat it and get better, and that's it. So that's why prevention feels alien sometimes, because you're so used to just dealing with problems. And again, you don't join the dots necessarily and think about kind of what the impact is on somebody's mental well-being. But of course it is. We are one body with a complex multiplicity of systems that of course are going to interact with one another. So that link is definitely still underplayed in traditional medicine. I think where I do think that kind of longer consultation, that functional medicine, holistic kind of consultation allows you to get into some of those considerations. And actually, I often find with patients when I'm on the kind of the non-NHS side, when I'm doing something that is more time, more lifestyle medicine focused, we are thinking very much about, what somebody's mental health is doing throughout a day, a week, a month, alongside everything else. And that full picture then helps us go, okay, this is probably what's going on. This is how we're going to help to manage the different symptoms. And it is transformational, and it has a longer lasting impact. I think some of our challenges in the NHS is because it is quite short-termist at the moment. We treat the one thing that comes in through our door. We don't get to the root cause. We can't deal with the wider kind of underlying issues. So that condition, those sets of conditions will persist. Whereas when you're thinking about lifestyle medicine and prevention, you are trying to get ahead of it. And I think it's still going to take a long time for that prevention mindset to really embed itself in the NHS. There's some great examples, but it's very hard to double run a prevention system and a reactive illness system at the same time. Cost alone is challenging in a growing kind of society. So whilst that's there, you unfortunately have a bit of a two-tier system where people who know or can afford to get more into the prevention space, and where people don't, they end up still in that reactive space. The 10-year plan talks more about prevention. I think we are also in the space, we talked at the top about kind of what incredible things are coming in the next 5 to 10 years. And like I said, this stuff is already here. Personalization, really thinking, using, genetics and genomic sequencing to think about people's individual, personal, very tailored plan. Obviously, the role of AI and tech within that. So those things are there as well. That will help us get into prevention more. But we need to make sure it's for everyone and not just for some. And that's the risk that we are in, not just in this country, I think abroad as well.
I'm curious to know about the tech side of things. So I know you've done some work with Neko Health.
Yeah.
They're the body scanning company doing really interesting things. It's all about prevention, early diagnosis.
Yeah.
What do you see as the most promising technologies that could genuinely shift women's health in the next sort of 5 to 10 years?
It's great because there's so many exciting things out there. And one of the kind of real pleasures of the sorts of roles I've had over the last 20 years is watching them emerge and seeing some amazing kind of founders doing really exciting things. I guess a couple that stand out for me. So we all are starting to be more aware, and you mentioned wearables. But for me, it's the integration of wearables that feels really exciting. So I've got my Oura Ring, I've got my watch, I've got all my bits. But they'll tell me one bit of the story, and then there's kind of cycle apps that'll tell me another bit of the story, and then there's stuff that integrates with your work life in another part. Starting to pull all of that together, that feels really exciting. So it's not just having the technologies there, but it's the kind of pulling together and then personalizing it for an individual. And I'm starting to see some really interesting things there. I touched on it before, but I do think we're already able to do really smart genomic sequencing that allow us to build out what's called polygenic risk scores. So scores that will help you understand at an individual level your risk of different things. So when it comes to women's health, your risk of cardiovascular disease or early menopause or endometriosis, building those in really soon will change the game in terms of how the clinician works with a patient, with not 2 or 4, but with a patient, to sort of go, look, you've had these symptoms. Actually, your chances of endometriosis are much higher than the general population. Let's do these diagnostics now rather than waiting 10 years and get ahead of it. And that helps somebody's fertility, like we said. It helps their menopause ultimately. So I think the practical use of genetics and genomics in kind of care now is the thing that's going to make a real difference, I think, mainly for women, because it will help us personalize care. Linking that to the wearables piece, continuous hormone monitoring, our ability to do really tailored HRT will be really fantastic, because at the moment it is fairly blanket. Like I'm quite nuanced in the HRT I prescribe in the NHS, but the reality is there's a bit of estrogen, there's a bit of progesterone, and then sometimes some testosterone. It's not very nuanced. We are starting to see technologies that will allow us to be much more tailored to what a woman is going to respond to and what a woman needs, and that's going to be great.
What sort of technologies? Pretty curious.
So the continuous hormone monitoring helping us. So if you think about people with diabetes who have continuous glucose monitors, and we've seen them kind of come into the mainstream kind of consumer market, and people will have them on and go, oh, I had ice cream and my sugars went up, and you're like, yeah, that is what happens. But it's still useful because it helps to put bits of the picture together. So this is more broadly for kind of female hormones. They're in trial status now, and that feels really exciting for me, because that is when you can really start tailoring hormone care for women. But actually, I'm a big fan of really simple innovations as well. So one of my personal bugbears is from the early 1900s, the speculum, the plastic device that's put in you to take your cervical screening sample, never changed. So it was a guy who tested it on black women without any anesthetic and stuff. He did a range of kind of experiments on women. So no wonder women don't trust health services. But anyway, that hadn't changed for years. And it's only the last year, I think, that Delft in Norway, some women have come up with a new type of speculum. Because at the moment it is cold, it's brutal, it's put up you, it's pushed open. No wonder women are a bit like, oh, cervical screening, I'm not sure. They've come up with a much neater design. So again, I think where more women are empowered and have knowledge of some of the stuff that is important, not just for them, but for other women. My friend had this, I want to design something like that. How brilliant, because those innovations are going to come to the fore as well. And then we'll all get the benefit as well.
Yeah, and with the genetics side of things as well, what would that look like? Would that be, just a blood test? So you could see certain genetic traits that you might have that could lead to an issue.
Yeah, exactly. So you do a blood test. It'd be part of your normal blood draw, and it's stuff that in some of my roles we've been kind of looking at already. So you get your bloods done, a kind of baseline bloods as you would do either in the NHS or if you went to see somebody privately, your hormones, but also your genetics is a genomic sequencing. So it looks at particular parts of your genetic profile to see what your risk is of particular conditions. So, no more painful or uncomfortable than your normal kind of blood draw. But it gives us loads of information as clinicians. And that's exciting because you work with scientists as well, but with scientists and clinicians, and you're able to sort of really help a woman understand the sorts of things that might be coming up. And you kind of triangulate it then to the symptoms that a woman's feeling, and then therefore the type of care that they might need.
I love that. I think it's all about individualized approach, right?
Exactly.
And diet and lifestyle, we are all so different. Yeah. And the fact that we've all kind of just had the same things, or like maybe there was variation in the type of contraceptive pill you'd be on. But really,
it's basically the same thing. And on that, like outside of the contraceptive pill, but actually that as well, most things have been tested either on men or on male rats, or mice. It's no wonder that women have 50% more side effects on any medication they're given, because most medications were not tested on them or for them. So even at a basic level, again, back to where we were before, even at a basic level, women are really underserved. So that individualized approach has to be the way forward.
And in terms of the next sort of 5 to 10 years, you've worked within the NHS for a long time. Like, do you think people will have to go privately to get that level of detail? So holistic approach, longer appointments, genetic testing potentially, lifestyle, maybe incorporating tech more. Do you think that is really something we, as women will have to save money for or have insurance for?
Guys, it's so unfair, isn't it? Because everything that I've talked about in parts is available in different ways in the UK. But yes, people are having to pay for that at the moment. Now, there's a couple of things. I have no issue with people paying for things, going privately. It does take pressure off the NHS. Having said that, the only way that we genuinely make this sort of care accessible for all is by commissioning it for everybody through the NHS. So the NHS is definitely up for it. There are both the leaders of the NHS at the moment, the leaders of local systems are saying, we want to build this in. We want to make this accessible for the people in our communities, not just for the kind of the select or the people that save up or can save up. So I think there's an appetite for getting this sort of stuff into the NHS, definitely. People are very kind of very aware of kind of all the kind of big tech innovations and stuff that's already here. So I do feel that that's something that is going to be more and more accessible. On that 5 to 10 year thing, I think in the first 3 years, probably not, but later in that period, absolutely. And that's exactly how it should be. We should be commissioning the best technology and the best kind of diagnostics, the best interventions for our population as a whole, not just a subsection.
Yeah. And I guess people will feel, with their taxes, that they'll feel happier that, things are maybe moving in the right direction. Because that is a sticking point for a lot of people. I was literally speaking to someone the other day who's got herniated discs in their back and said, I can't get surgery. I'm on a very long waiting list. And I've been paying a lot of tax all these years. And what am I paying it for? And I think that's a big question. Obviously, that's more political. But I feel like just if you had the sense of walking in and the technology is there and the time is there, I think that would make a lot more sense for people going forward. Very, very quickly, because we're running out of time. But I'd love to know, are there any health practices that you incorporate? Obviously, probably not so many during the time we were talking about at the start during COVID, but now, what sort of practices do you do to kind of look after yourself?
Well, I think first of all, we touched on this a little bit earlier around kind of how women are, the pressure women have in society. So thing one is I'm just a lot kinder to myself. When I say I grew up, I grew up in the health system working as though, that 4-hour, almost Margaret Thatcher type, sleep window was aspirational. And actually I'd be congratulated on it. Oh, wow, you only sleep for 4 hours? I'm like, yes. And I have 8 coffees during the day and everybody would be like, oh my God, you're amazing. So I try to both lead my life and lead in a way that is much more authentic to kind of the things that are important. So being kind to myself, getting rest. I'm terrible at journaling, but that little 5-minute journal I do with my kids before bedtime, just a little bit of reflection on the day. My meditation, and I'm a mindfulness and I'm a Reiki practitioner. So, but I'm still not good at following my own advice. But every morning, trying to just do a moment of mindfulness that helps me kind of connect into myself, just to set myself up well. We have a strict kind of no phones when we wake up in the morning. That's as the kids are navigating their relationships with phones as well. Getting that sunlight in, that's a really important practice. People won't always have time to do all of the kind of the movement that we need to do. So I do a lot of reformer and yoga because that's important to me. But walking is so important, and particularly as we go into the winter months, walking while there's daylight out. So I often say to my teams, especially as the days get darker and shorter, okay, your lunch break is not in here. You're out, get outside. So rest and normalizing rest is important. Movement, even if it's walking. And I don't want to say just walking, because walking is important. Getting outside, getting daylight, journaling, and just getting some space. Take the baggage out of it. It doesn't have to be like half an hour of journaling or meditation, but just a few moments to connect back in. Those small practices stand you in a really good stead. Wider than that, it is about people and community and connection. We are social creatures, particularly women, I think. So having that time to connect in with people, to recharge is honestly just so crucial to your mental and your physical well-being.
I absolutely love all of those. And I feel like it's also like hearing you say that shows the evolution of health, where for a long time it's been like, okay, good food, maybe no alcohol, and exercise, but actually there's so much more to it. Things like the mental health, the stillness in the morning, the sunlight. That's now more and more evidence for sunlight being so important to our mitochondrial health. Again, like these other sides to our mind and just being kind to ourselves and connection, community. These things are so important, and I really love that you're prioritizing them. I'm still working on, many of those things myself, and I think hopefully when we hear that each other, we're doing these things, it kind of encourages you to kind of gives you the motivation. Dr. Nikita, thank you so much for coming on the Health Review. I feel like we could sit here all day. I have like another list of questions, so it means I'm going to have to get you back very soon.
Anytime. Thank you for doing this. It's so important for people to kind of delve into these topics. So.
And for anyone who wants to keep up to date with everything you're doing, career, everything, where can they find you?
I'm on, so depending on what you're looking for, I'm on LinkedIn as Dr. Nikita Kanani MBE, and I'm on Instagram, Nikki_Kanani. So often posting about health, but also community, belonging, identity, because much as we were saying, it's that whole lens on yourself that helps you understand who you are and who you need to be.
Dr. Nikita Kanani MBE, thank you so much for coming on the Health Review.
Thanks so much.